If you've been following along, in previous episodes, we talked about how chronic low-grade inflammation is a driver of anxiety in kids, not just a consequence. We know that the HPA axis, cytokine signaling, and neuroinflammation all feed into each other. Today, we're looking at the same inflammatory machinery in the body, but through the lens of sleep-disordered breathing. And I want to hold that previous framework in mind because there's a lot of parallels that we're going to circle back to. Is it a chicken or the egg? What comes first, the inflammation or the sleep-disordered breathing, and then the inflammation? What we know now is the immune system doesn't silo its problems. A child whose brain is inflamed from sleep deprivation and hypoxia is also a child who is more anxious, more reactive, and harder to settle. These stories are all connected. Today, we're discussing the sleep-specific part of the story. So today, I'll be walking you through a 2025 study out of China that looked at 4 specific cytokines: IL-4, IL-12, IL-13, and TGF-β in children with sleep-disordered breathing. And I want to spend real time on the so what. What does this mean for how we understand sleep-disordered breathing? So this is the study that we're reviewing this week on Monday Study Rundown. There's a retrospective study, 107 children with sleep-disordered breathing compared to 75 healthy controls, ages 2 through 12. All the children with sleep-disordered breathing did a sleep study with overnight polysomnography and then proceeded with tonsil and adenoid removal, adenotonsillectomy. They did blood draws before the surgery and then analyzed again after the surgery. So why did they just yank their tonsils? Adenotonsillectomy, a removal of the tonsils and adenoids, sometimes called a TNA, really standard for treatment of obstructive sleep apnea in children. I have a lot of opinions about this. Obviously, I prefer not to just immediately pull tonsils and adenoids in children, but it is a pretty well-documented intervention for obstructive sleep apnea in children. So in this study, they, again, had the blood drawn before and then after to compare the levels of cytokines. In this study, they classified the severity by something called AHI. It's essentially like an apnea index of how severe the sleep apnea symptoms were, or the sleep disordered breathing symptoms were. They classified it by mild, which is 1 to 5 per hour, moderate, which would be 5 to 10 events per hour, or severe, which would be greater than 30 per hour of symptoms. In the study, they had 30 patients in the mild category, 43 in the moderate, and 34 in the severe category. So why did they do this? Well, the polysomnography, or a sleep study, we'll just call it a sleep study, it's easier to say, is the gold standard for sleep disordered breathing diagnosis, but it is expensive, it's time consuming, it's not always accessible. So the study was asking, can a blood panel do some of the diagnostic work that a sleep study could? Like, could we predict which children have obstructive sleep apnea based on the blood work, not having to put the children through this whole rigmarole of being hooked up to all these monitors, sleeping in a strange place? The short answer is not really. Just like my short answer for the anxiety episode was not really, but there is an association. And of course, it's just not specific. But the biology is pretty interesting, so I'd like to talk through some of these things here. So what the study found is there are a few cytokines that are elevated in sleep-disordered breathing. These are pro-inflammatory cytokines, cytokines that are causing or producing inflammation in the body. One was IL-4, which is a Th2 cytokine. It's known to promote fibroblast differentiation, collagen production. It is correlated with obstructive sleep apnea. It's also linked to cognitive dysfunction in patients with sleep apnea. So that's something really important to note, because we're going to tie that back to ADHD in a little bit. And then IL-13 is also a Th2 pro-inflammatory cytokine. It has the strongest individual correlation with sleep disordered breathing severity. It's well connected to asthma, which is also connected to obstructive sleep apnea. And this is all, again, interconnected, which is also super relevant because we see sleep disordered breathing and asthma comorbidity overlap a lot in practice. And one of the things I think could be really helpful for us to tease out in research in the future is, where is the chicken and the egg? Which condition is coming first, or maybe they're just coexisting and we need to treat both simultaneously. TGF-β was also elevated, which promotes fibrosis. It suppresses NK cell activity. It is elevated via oxidative stress pathways. It's usually anti-inflammatory and regulated. Elevation here, at least the researchers are sort of suggesting, reflects a system under chronic stress, and that's why it's elevated. And then reduced in sleep disordered breathing. IL-12 is a Th1 cytokine. it tends to counterbalance the pro-inflammatory Th2 cytokines. So a lower IL-12 indicates a more severe sleep disordered breathing. IL-12 is a Th1 cytokine. Just as a reminder, Th2 and Th1 are on sort of a teeter-totter. When the scale tips into a Th2 direction, that's a pro-inflammatory direction that's more associated with asthma, allergies, and eczema. So Th1 would be the balance to that. In most cases, we don't want to skew too far in one way or the other, but the Th1 cytokines do tip the scales in the other direction away from allergies, asthma, eczema, so to speak. So IL-12 is that Th1 cytokine. And what they found is that lower IL-12, so lower of the scale balancing, leads to a more severe sleep disordered breathing pattern, which makes sense. It doesn't tip that teeter-totter back to equilibrium like we want it to be. It basically would behave like a protective marker that the body can't maintain as the disease worsens. So what we're seeing here is a Th2 dominant pattern, not enough balancing on the Th1 side, way too much on the Th2 side, which makes sense if we think about it, because these children with sleep disordered breathing tend to have higher rates of eczema, asthma, food allergies. And I think that maybe now we should put sleep disordered breathing into a Th2 dominant pattern organization. We always say the atopic triad, which is those three: asthma, eczema, food allergies, but sleep disordered breathing should probably go in a quadrad or something like that to fit in that Th2 dominant pattern. This is something to be aware of in your young patients who have eczema or wheezing or reactive airway, so it doesn't progress to a sleep disordered breathing pattern. And then we're going to link this into ADHD here in the end as well. They're trying to see if we could sort of predict a sleep disordered breathing pattern. But the really important and interesting part after this, I think, is the improvement in the pro-inflammatory cytokines after tonsillectomy, adenoidectomy. What the study found was that the pro-inflammatory cytokines basically all improved. So after tonsillectomy, IL-4, IL-13, TGF-β all dropped, and IL-12 rose, which is what we want to see. This is probably the strongest evidence in the paper. I believe this is the first study that has shown that pro-inflammatory cytokines improve once sleep disordered breathing is resolved or improved significantly. However, the kids with a very high or persistently high AHI, that apnea index after surgery, did not fully normalize. The research shows that a certain percentage of children do not respond to tonsillectomy, adenoidectomy. This is something that I'm continually discussing with my patients, and I have mentioned in other blog posts and in interviews. And it's one reason that I'm not against tonsillectomy, adenoidectomy for children, but it's not really addressing what's happening. Only pulling tonsils and adenoids doesn't really change the shape of the face, that change the shape of the airway opening. I have mentioned before that I am quite a big fan of orthodontic devices and palate expansion for children, which is not where the research is really supportive, unfortunately. So this is the part in clinical practice where we get to weigh our personal experience against research. I have had very good responses referring to functional dentistry or conventional orthodontics for children with enlarged tonsils and adenoids, and for children with obstructive sleep apnea. For the older children, just classic orthodontic technique of the permanent palate expander is very effective. In the younger age group, there are a few functional dentists that are using some sort of like retainer type devices to expand the palate in even a very young age group, as early as 2-3 years of age, way before this sleep disordered breathing typically peaks. I often see in my practice, it's about its worst around age 4, 5, 6, 7, and then tends to get better as children basically get bigger and their oral airway improves. I've had a lot of conversations with dentists about that. I have a few dentists, colleagues and friends in town who are really big supporters of doing palate expansion and talking about how important that is for airway management. I've had a few orthodontists say, why would you ever even bother doing these appliances in a younger age group when I'm going to see them anyways when they're older for orthodontics anyways. But the reality is they don't see the older the patients who respond in early ages. And we often don't have time is the biggest problem. So that's really one of the issues here and the pros and cons of tonsillectomy versus what's called rapid maxillary expansion. Rapid maxillary expansion is the palate expansion for patients. Rapid maxillary expansion takes months. About 6 months is what I've found for it really to be effective. If a child is not breathing, they're actually having significant inflammation and low oxygenation at night, which can have permanent consequences to intellectual development. It's quite serious. And so for those cases, a tonsillectomy and adenoidectomy may be our only option to help improve that sleep disordered breathing as quickly as possible. Circling back to the study a little bit, the question that the researchers have that I have as well is what's the cause and effect? Where is the chicken and where is the egg? The cytokines are elevated in kids with sleep disordered breathing, but is the inflammation causing the obstruction or is the obstruction causing the inflammation? What they sort of suggest is, they suggest sort of both, but tonsillectomy, adenoidectomy, improving inflammation suggests that it is in that direction. So researchers are suggesting that intermittent hypoxia, intermittent drops in blood oxygen is activating NF-kappa B and this thing called NLRP3 inflammasome. And that is what's creating this systemic cytokine release. What they're suggesting is because the tonsillectomy and adenoidectomy, afterwards, these children are normalizing in their pro-inflammatory cytokines, that supports the probability that it is the sleep disordered breathing that is the cause of the inflammation. They're also suggesting that because a certain percentage of children who still have sleep apnea symptoms after surgery don't fully normalize, those are the kids who still had that high AHI after surgery and their pro-inflammatory cytokines didn't get better. That suggests that obstruction is the primary driver. However, it's not completely one directional. It does seem to be a cycle. And it's a cycle because it also affects the tonsils and adenoids directly. So if we get inflammation in the adenoids and tonsils, we have activation of IL-17, TNF-alpha, IL-6 via NF-kappa B, all these things. It leads to lymphoid hypertrophy. It leads to an increase in the size of adenoids and tonsils, which further narrows the upper airways, which leads to intermittent hypoxia. It leads to these sleep disordered breathing events and low oxygen in the bloodstream and sleep fragmentation, which then leads to systemic cytokine release that we've already discussed, which then leads to more local tissue remodeling, more fibrosis, and more obstruction, which leads us back to inflammation in the adenoids and tonsils. I hope that makes sense. So this is why treating the tonsils alone doesn't fix everything. You've treated the mechanical blockage, but if there's still systemic inflammation, then there's still going to be an inflammatory environment that leads to further obstructive sleep and further issues. And similarly, if the underlying cause has not been addressed, say the child is still exposed to persistent allergies, mental pollutants, they're not on an anti-inflammatory diet, they have a pro-inflammatory diet and ultra-processed foods, or they have recurrent infection, recurrent strep throat, or they're a carrier of chronic infections, then we haven't broken the cycle and this is going to continue, even if the adenoids and tonsils are gone, because there still can be fibrosis in the other areas. There's a little bit of nuance with TGF-β. It usually acts like an immunoregulatory brake. It's usually anti-inflammatory, But what the authors are suggesting here is because it's elevated in severe sleep disordered breathing, it is sort of like a marker that the system has lost its regulatory capacity. TGF-β actually drives fibrotic airway remodeling, so it increases fibrosis in the airways, and that can make obstruction worse structurally. Okay, now I want to bring in the ADHD connection because this is where it gets more clinically relevant for a lot of us in practice. The sleep disorder breathing ADHD link, and I'm guessing most of you see with children with ADHD symptoms regularly. And if you're not already screening for sleep disordered breathing, you definitely should be, and this section is for you. There's a lot of evidence here, very strong evidence of obstructive sleep apnea in children with ADHD. About 44%, they think, based on a 2026 meta-analysis, 44% of children with ADHD actually have obstructive sleep apnea. Co-occurrence, one or the other, is as high as 50% in studies, and even mild sleep-disordered breathing, even like mild snoring, is associated with increases in inattention and hyperactivity scores. Even the smallest amount of sleep-disordered breathing causes worsening of ADHD symptoms, and I'll tell you from experience, behavior problems in children, which is usually what I see or parents are complaining of first. In this case, it is definitely documented to be bidirectional. ADHD increases risk of obstructive sleep apnea, and obstructive sleep apnea increases risk of ADHD. And those are actually genetic studies, which are pretty good. So there's less confounding. So it's really like real evidence here. There is a lot of overlap with these cytokines. One study in particular found that IL-6 as a specific cytokine might even predict an ADHD diagnosis in children with obstructive sleep apnea. There seems to be an even increased effect when they overlap. So children with obstructive sleep apnea and ADHD have even higher levels of IL-4, IL-12, and IL-13 and lower TGF-β compared to children with just obstructive sleep apnea. The studies definitely show that improving sleep-disordered breathing or treating sleep-disordered breathing improves ADHD symptoms. What some of the authors are actually suggesting is that at least some quote-unquote ADHD in kids is just sleep-disordered breathing, and it's the sleep-disordered breathing that's driving neuroinflammation, and that is what's creating the symptoms and is actually reversible if you treat the sleep-disordered breathing. So if you have a child in your practice or in your home with ADHD who's not responding well to behavioral strategies, naturopathic therapies, medications, supplements, sleep should be really addressed very quickly and treated appropriately. So naturopathic perspective, I already gave you a little bit of my perspective on rapid maxillary expansion or palate expansion for children. Using a sleep study is still the diagnostic standard. We're not really measuring cytokine levels in kids. We already discussed in another episode how those cytokines can predict anxiety as well. So it's not like we can measure cytokines and say, oh, you definitely have this. So I still recommend doing a sleep study for children when we're suspecting obstructive sleep apnea. The research shows that for moderate to severe obstructive sleep apnea with tonsils and adenoids that are enlarged, that tonsillectomy, adenoidectomy is appropriate. I still think if tonsils are small to mid-size, that trial of rapid maxillary expansion is fantastic first, because it helps us avoid surgery for children in a lot of cases, which is fantastic. For the kids who have tonsillectomy and adenoidectomy, many of them still need orthodontic treatment or rapid maxillary expansion. They just tend to have a narrow face, a narrow oral airway, and it does seem like rapid maxillary expansion or myofunctional therapy. Naturopathically, as a naturopathic doctor, I would always make sure we're addressing the other factors that can be involved in enlarged tonsils. Mostly that's air pollutant exposure. Here in Missoula, Montana, we get nailed with wildfire smoke every summer. So that would be the number one. Removing pets from the bedroom, having HEPA filters in the home and in the bedroom especially or particularly, allergen covers on the pillows, make sure a patient's allergies are treated appropriately. Make sure their asthma is treated appropriately. A diet high in flavonoids is really helpful for reducing inflammation, even systemic inflammation. So I've mentioned a Mediterranean type diet, I don't know how many times, but lots of colorful fruits and vegetables, and especially dark berries, which are potent antioxidants and kids tend to really like to eat. So things that this study changes for me in my practice, knowing that kids have this chronic inflammation or this chronic inflammatory cycle makes me very uncomfortable as a naturopathic doctor. If they're not responding to anti-inflammatory naturopathic therapies, then I think we need to move on and really address airway management as quickly as possible. And as we mentioned before, I think addressing allergies is really important. We have a number of naturopathic therapies that can be really important and really helpful, but seeing an allergist also, considering allergy shots could be helpful. A number of anti-inflammatory, antihistamine medications, supplements could be really helpful. There's one little note here too. Repeated upper respiratory infections actually sort of like reprime the NF-kappa B pathway and help drive the cycle that causes the adenoids and tonsils to become enlarged. So every repeat upper respiratory tract infection is going to enlarge those tonsils and adenoids. In good circumstances, that comes back down after the infection, but if they just keep getting sick, that's going to keep getting bigger and bigger and bigger, which is going to drive sleep disordered breathing, which is going to keep their tonsils and adenoids enlarged. So helping prevent infections, hand washing, all of our good naturopathic therapies are really important. And then just sleep fragmentation in general will worsen this. So making sure children are getting to bed at an appropriate hour, that we have all the behavioral components in place, I think is really important. Let's talk about limitations of the study just for a minute before we kind of close out. It was one retrospective study. It was a single center in China. It hasn't been replicated yet. There's no reason for me to think that this would be false information. I think that the studied relationship between ADHD and obstructive sleep apnea and the pro-inflammatory cytokines are actually already known. So this really just reinforces and helps give us a little more information about what direction it is heading in, which seems to be mostly the obstruction leading to the inflammation, but with all those caveats in there. They did only really get good data on those 4 cytokines. There was no adjustment for obesity or BMI in those cytokine calculations. So that could be way off. So that's a little bit difficult. And then of course, we cannot prove causality from the design of this study. Children with sleep disordered breathing are not just obstructed. It is not just air or oxygen that is the problem. It is inflammation. That inflammation seems to track with severity. It actually normalizes with treatment. And it seems to be part of a self-sustaining cycle that connects obstructed airways to fragmented sleep to chronically dysregulated cytokines that then leads to neurocognitive consequences. And it's that last link, that's the inflammation to the brain link that connects everything we've already been talking about in this podcast: ADHD, anxiety, autism spectrum disorder, even talking about gut microbiome metabolites and other things that we mentioned in last podcast episode. So this is how much things are interconnected in the human body, which I think we know, but when we really dig in, it is multifactorial. And this is why treating children for ADHD can be really challenging. And having one therapy fix the one thing doesn't always work for kids. So think about this. I would strongly recommend screening for sleep disordered breathing in every child presenting with ADHD. If there's a 40+% overlap, that better be fixed first, because a child who's put on a stimulant medication but hasn't been assessed for sleep disordered breathing, that's really a shame. When surgery is appropriate, I do support it, but I don't stop there. I always address and assess the inflammatory environment and treat those factors as well. And I see or give a trial for non-surgical methods of interventions when appropriate and when the obstruction is not super severe. The study will be linked in the show notes along with the MSR post, the Monday Study Rundown post, if you want the full breakdown, including the cytokine tables and all the data. And if you haven't taken my pediatric sleep course yet, it's called Solving Pediatric Sleep Problems. It is a course for healthcare providers that will be linked in the show notes too. I'll see you next Monday. Thanks for listening to the Naturopathic Pediatrics Podcast. If you found this episode helpful, please subscribe, leave a review, and share it with a colleague or parent who might benefit. For articles, resources, and evidence-based natural health information, visit naturopathicpediatrics.com for parents and caregivers. If you are a healthcare provider, though, and you would like more evidence-based pediatric content, head over to Naturopathic Pediatrics Pro, which is pro.naturopathicpediatrics.com, and sign up for my Monday Study Rundown. Every other Monday, I summarize a new pediatric research study and discuss how it applies in real-world clinical practice. I'll see you next time.